The definition of interventional uroradiology is interventional radiology is a specialty of radiology that uses minimally invasive image-guided technique to both diagnose and treat conditions throughout the body. Its outlines as of this subject is percutaneous nephrostomy, percutaneous renal abscess, PCNL, and this list of indications at the same time. It's indications of the interventional radiology are the common subject, and this type of interventional uroradiology should be done with the collaboration or cohesiveness between the radiological departments and the radiological departments and the urological departments. One of the indication is percutaneous nephrostomy. It's one of the most commonly performed interventional procedures. It's frequently performed in the hours of the outpatients, and you should have a good knowledge and background of anatomy to be familiar with all the structures and the surface anatomy of kidneys and its internal anatomy, the nearby structures. This is just an illustration showing the kidneys itself and the patient which is in prone position. It shows where the kidneys anatomy in a very simplified way, renal arteries, renal vein, and renal pelvis has been shown. And then this procedure is done under ultrasound guide or under a CT guide or under fluoroscopy. You can do a nephrostomy tube and you puncture into the lower pole calyces, targeted calyces, and then you do the procedure. The indications are temporary way you are going to do nephrostomy to divert urine due to a distal obstruction, urinary excess for urological interventions like PCNL, ureteric stent insertions, pylourethoscopy, direct infusion of the chemotherapy, and sometimes you have got ureteric stricture, PUJ stricture. You cannot do it from below. You are going to do it endopilotomy. It's called endopilotomy, laser endopilotomy. You cut the strictures by lasers, and you put a JJ stent in situ. Other indications are diversion away from the fistula. You have got a fistula from below, distal fistula, for example, in the distal ureter. You go and to divert in order to stop leak of urine and to do more definite procedure later on, and to drain a pyonephrosis, hydronephrosis in transplant kidney as well. There is no absolute contraindication, and relative contraindication are bleeding diathesis and uncooperative patients, because uncooperative patients are making problems. They are really panic to the procedures, and they do not allow you to do your because these procedures are done under local anesthesia, so they are not cooperative and makes problems for you, and during your procedure it will move and make your procedure unsuccessful. And this is a sequential steps of how you do a percutaneous nephrostomy. First, you put the needle under ultrasound guide inside the targeted calyces, usually a lower calyces, and then through this you take out the needle and the trocar remains, and you push in a guide wire, and then over the guide wire you are going to do a sequential dilator of the tract, and then at last E, as shown, catheter you put inside the kidney. Below is the ultrasound showing the arrow in the A shows the dilated calyces, and in the B it shows the needle, and in C is really where the nephrostomy should be such. Complications are any other complication. You have got a specific complication and non-specific complications. One of the most basic complications is hemorrhage and urine extravasations around your nephrostomy tube, injury to the nearby structures in the right kidney. You should know the entry of the left kidney. Bilateral, you may have a pneumothorax, and pneumothorax mostly on the left side because the kidney is higher than the right. and injury to the surrounding structures, sometimes due to if long-standing catheter is there, or the patient forget to come to the hospital to change or to remove the catheter, there will be crystallization and it's difficult to be taken out. The mortality is 0.3, less than 0.3%. This is a nephrostomy tube, and you should have a guide wire, which is not shown clearly. It's a nephrostomy. In cases of nephrostomy, it is in PCNL, the nephrostomy or puncturing of the calyces is the first step, is the most important step of doing PCNL, and after that, once you enter the calyces, you are going to dilate. There's a special set, either it's a plastic or metallic set. You are going to dilate, say functional dilatation. After at the last, you put a implant sheath instead of nephrostomy tube. You put implant sheath inside, and then by means of fluoroscopy, you are going to visualize inside the calyces and to do lithotripsy of the stone or fragmentation, whether by laser or by pneumatic. Contraindications. There is no absolute contraindications, and we have got relative contraindications. Although there is no absolute contraindication, but some situation is nearly the patients, as I mentioned previously, is, for example, have got severe sepsis. Sepsis infections is a contraindication to proceed to doing PCNL. You should put a nephrostomy and treat the infection, and then you are going to come back and to do your stone fragmentation. Relative are comorbid patients for general anesthesia or for local anesthesia as well, or comorbid for prone position, because these procedures, although can be done in supine position or semi-supine position, it is mostly generally done in prone position under general or under spinal anesthesia. Obesity is one of the contraindications of percutaneous, morbid obesity. Untreated infections, as I said, coagulopathy, severe kyphoscoliosis, precluding adequate approach, congenital anomalies or skeletal anomalies, and in pregnancy. These are the sequential steps showing the fluoroscopy or X-ray to gain access into the targeted calyces. This can be more, it's step by step. The first step is the visualization of the kidney, and then the second and third one is to modify your pictures of CRs in order to be sure that your needle is inside the calyces. And then after that, you puncture and the urine comes, and then you put your guide wires, and then you do your procedures. Complications, minor and major complications. Minor is 10 to 25 and major is 2 to 7. On the top is infections, hemorrhage or delayed hemorrhage, IV malformation, pseudoaneurysm, chest complications, sometimes infections, pneumothorax, infusion, extravasations of your fluid to the surrounding structure, and there is injury to the pelvis or to the calyces, and surrounding injury to the surrounding structure. Sometimes it's difficult to go to put a stent from below in case of ureteric obstructions, or difficult to find out the ureteric orifices. This is due to invasions, usually by tumors, for example, or by malignancy of the bladder, or the prostate, or in female cervix, and sometimes a big tumor, rectal tumors, from in case of a general surgery. In long-term relief of obstruction, ureterial stents are preferable to nephrostomy because of practically the patients are first very difficult for the patient to have a drainage tube externally, and it's more prone to infections, and it have a bag and sometimes leakage of urine, infection. So it's better to have a stent rather than if you are able to put a stent rather than to put a nephrostomy. So it can be done by doing sequential dilatations of your nephrostomy tract and then go inside, do by flexible inside the upper ureter, visualize the stricture or visualize the obstruction, put the guide wire downward, and then put the stent. As it is explained in this picture, you know, from A you find out there is a holding in the lower down, lower ureter, near the atriovesical junction, and then the surgeon has gain entrance into the calyces. He put a guide wire, and then over the guide wire, now it's putting a JJ stent. And this is a usual procedures when you have got a stricture that you cannot negotiate or you cannot put a guide wire or dilate from below. Indications of this type of antegrade ureteric stenting is malignant strictures, benign, obstructing ureteric calicus or bicalculus, adjunct to Ismail, and ureterial injury due to surgery or due to trauma, ureteric fistula. Now, if you have got, for example, ureteric strictures, you go from above and you put the guide wire, and then due to a malignancy, you put inside the guide wire, for example, a colonic malignancy invading the right ureter on the right side or descending colon on the left side. Usually these patients are sent by general surgeons, or in cases of gynecological lower down, the patients is usually sent by gynecologists and by oncologists. They are saying that the kidney is in bad situations and it's cytonephrotic and obstructed, and it's better to have relief of obstructions for general condition of the patient, and in order to give the chemotherapy drug the patient to stand the side effect of this chemotherapy drugs in case of malignant strictures. In obstructing ureteric calculus, sometimes it's difficult to negotiate or to do JJ standing from below, or it's difficult to do lithotripsy or fragmentation of the ureter because of severe infections. So you just dilate the urine and treat the infection, and then later on you go back and you treat the patient. Adjunct to as well, when you put a stent and then you are going to fragment by this type of machine. I think most of you have seen the machine, which is extracorporeal shock wave. Ureterial injuries either by blunt or by penetrating trauma. You have got, for example, a surgeon has operated on abdomen due to a bullet injuries, and in that case it's an emergency and they are just saving the patient's life, doing most of the job, but in that at the time or the scene of the operation, due to bleeding and due to a lot of edema of the surrounding structures, the ureter cannot be visualized, and it is difficult to search for ureter, or or it has been missed the ureteric injury, or later when it is tangentially the bullet is going beside the ureter, there will be later on necrosis of the whole ureter, and then at the end by fistula and urine come out from the wound, and then at that time you are going, after diagnosis, you are going to do diversion of urine by doing nephrostomy, and then when the patient's conditions settle down, infections and edema all having revealed or relieved, then you are going to do a definitive surgery for the patient. Or you have a leak, urine leak. Contraindication, we have no absolute relative as in other procedures. Complications, common complications in doing stenting is, this stent irritate the trigone, and then the patient come to you from irritative bladder symptoms like emergency frequency dysuria. and suprapubic pain and loin pain. Why suprapubic pain? Because almost whenever the patient gets into site to urinate, some of the urine will go back to the kidney because the valve has been bypassed by the stent, hematuria, all due to irritations of the mucosa of the bladder, infections, and sometimes the stent is malpositioned. You have to repeat the procedures. The stent sometimes migrate upward or downward. Inadequate relief of obstructions and incrustations in long standing. Uncommon and rarely, I have seen cases that the stent is fractured into 3 to 4 pieces, and we have erosion of the wall of the ureter by the stent. This is the procedures. This patient has got a nephrostogram, the dye coming down in the pelvis, upper ureter. There is a filling defect in the upper ureter, and then the the stent has been put by the stone has been bypassed, and JJ stent has been inserted. Another indication is a renal biopsy. Renal biopsy is usually indicated. Indications of renal biopsy are renal failures, all types of renal failures, nephrotic syndrome, glomerulonephritis, and failing transplant kidney. Usually is done by nephrologists, although it can be done by surgeons. No obsolete, we have a relative contraindications: bleeding diathesis, hypertension, renal mass, pyelonephritis. This is the picture showing you simply how you take a biopsy from a patient which is in a prone position, and under ultrasound guide. It's ultrasound transducer to visualize the kidney, and then it will visualize your needle when it is entering into the kidney. And this is an automated gun type of needle biopsy. You fire, and then it will take a piece of kidney tissue. The ultrasound showing the needle inside the kidney, and the kidney itself is a sagittal kidney biopsy. Complications: hemorrhage, sometimes severe blood loss when you hit the segmental arteries, and the mortality rate is below 0.1%, just like that of the appendectomy, infection, and arteriovenous fistula, pneumothorax if you puncture the pleura, and surrounding structures can be injured in this type of procedures, and rarely. Another title which is not a new for the urologists, but it's a new for us. It's a percutaneous radiofrequency ablation of renal tumors. When you have got these radio ablations, you get access inside the kidney, and then you put a special needle. These needles, at the top of the needle, you can have a thermal, increase the temperature of the needle, so a special type of radio frequency, and then you heat the tumor, and it will cause induce coagulation, or it's called thermally induced coagulative necrosis at a temperature of 50 to 100, just like boiling an egg. It will be a coagulative necrosis. A growing body of evidence indicate that this type of treatment is effective for small renal tumor between 3 to 5, and below 3 and up to 5. Although its rate is not 100%, you are going to eradicate or coagulate the tumor. The success rate is 79 to 97%, which has written in literatures. However, it's good for those who cannot stand the operation and have got less complications in comparison to surgery, whether it's a laparoscopic or open surgery. It's usually indicated for high-risk surgical candidate, comorbid patients, like, for example, hypertensive, ischemic heart disease, diabetic, patient with solitary kidney, hereditary von Hippel, because in hereditary von Hippel-Lindau disease, it's multiple. You cannot, by whether laparoscopic or by open surgery, you cannot remove all these foci of the tumor, so you are going to do ablation by radiofrequency. Advanced disease, yeah, means the tumor is advanced. We have got, for example, complication of this tumor along with, for example, metastasis, and the tumor is advanced, so you are going to do just relieve the symptoms and palliative treatment, or in case when the patient is refusing surgery. Contraindications, no obsolete, relative contraindication, coagulopathy, sepsis, large tumor, more than 5 centimeter, and one of the, because in large tumors you cannot ablate all the tumors, or ablation is very impractical. It should not be more than 5 centimeter, and the tumor should not be close to the major vessels. Complication, list of these complications are that of nephrostomy or PCNL, and we have other complication like neuropraxia of the nerves nearby, ureteric stricture in cases if it's near the pugae, bowel damage, catecholamines, this is near the upper palm. You induce catecholamine from adrenal glands. Reflex catecholamine secretions, just like, for example, a trauma, residual unablated tumor, and needle track seeding of the tumor. This shows the picture in A big tumor, and in B it shows outer radiofrequency ablations. This is a CT scan, and you know how the tumor is decreasing in size. Renal abscess, other indications of or other procedures of minimally or interventional uroradiology or minimally invasive surgery is renal abscess. Although it's uncommon, but it's potentially life-threatening conditions. It's seen usually, or predisposing factors are recurrent UTI, obstruction by calculus, by tumors, or other mechanical obstructions, iatrogenic by surgery, or for example by after PCNL, or in case of diabetic patients, in case of a ureteric reflux, when the infection, repeatedly infection go up inside the kidney from the bladder, and in case of long-standing stone with infection, which is called vasogranulomatous pharyngitis. Other causes, seeding of bacteria from focus of infection, otherwise in the body, and it will seed in the kidneys and cause infection. For example, in case of impetigo, which is infected skin lesions in children, or in case of pneumonia, and can to inoculate the bacteria in the kidney and cause abscess, especially staphylococcus in such conditions, or instrumentation or trauma, as I mentioned. This is the radiological finding, an abdominal X-rays, radiological diagnose these cases either by means of intravenous urography, ultrasound, CT scan. The golden standard is CT, the ultrasound showing the tumor arrows are showing or indicating the whole of the abscess, and this hypoechoic or dark color internal or the abscess cavity, which is filled of pus. In case of CT, on your right side is the CT scan showing a big abscess of the left kidney, which have an enhanced wall and the abscess cavity. Management, medical management, you give antibiotic, especially prospectum antibiotic, and then you are going to start percutaneous drainage under whether CT guided or ultrasound guided drainage, and then you put a nephrostomy to secure drainage until the cavity will be shrinked. And it may need more than one catheter sometimes. Should be, you should aspirate until there is no more pulse. If the pulse is due to obstructing calculus, you have to put a nephrostomy, and if you suspect that the patient conditions or the abscess has not been evacuated completely, it is better to leave a nephrostomy tube in cases of obstructing calculus, or in case of distal obstruction, or in case that the general conditions of the patient has not been settled down, until you are going to do definitive surgery. This is the CD guided needle entering into the abscess cavity, and then followed by aspiration and putting a nephrostomy tube inside, especially when it's a big abscess. Always leave a nephrostomy tube there. This one is on the top or your website is a CT scan and a big abscess on the left kidney, and then the patient has been put on the prone position, and the second picture on your right side, above picture on the right side of the corner, the needle entering into the cavity, and then the guide wire has been inserted through the guide wire. You put your drain tube incision. Complications, septicemia. All septicemia may cause multiple organ failure and probably sometimes death. Spread into perinephric space due to leaks through your nephrostomy tube, or into peritoneal or pleural cavity. Fistula formations, GIT or infections into the surrounding, and bleeding. Suprapubic cystostomy, it's a drainage of the bladder via suprapubic road. It's a common procedure in both the acute and chronic clinical setting. There are three main circumstances of suprapubic exercise. In acute setting, whenever you have got acute obtention of urine and you are unable to put a catheter from the urethra, so you are, whatever the cause is, whether it is due to a stone, whether it is due to a trauma, whether it is due to bleeding, or it is, for example, it's contraindicated to put due to severe infection, to put a catheter from below. So you are going to put a catheter from the above. In cases of what is called surgical cystostomy or formal cystostomy, you put, in case of chronic one, you have chronic retention of urine or chronic bladder outflow obstruction. In these cases, when you put a catheter, it's better your catheter should not be more than 3 weeks. And if you have got such a cases and you suspect that the catheter will remain more than 3 weeks because of high chance of infection, it's better to do a suprapubic cystostomy because the chance of infection is less than that to put a catheter from below. The other one is image-guided suprapubic cystostomy. In some circumstances, we have scar in the lower abdomen, and whenever you have got a previous operation, there's possibility that some loop of valve is very close in contact with the bladder, and there is possibility to go through this valve or to injure bowel loops, and to end with a complication. in this situation, you should do it by image guided or by this interventional procedures. So, in case, as I mentioned, indication for image guided is a bladder obstruction where surgery is contraindicated to be perfect procedures. In cases when you have got obesity, because fat is very difficult in case of morbid obesity to do under without image guided. In case of scarred lower abdomen, neurogenic bladder, because unable to palpate the kidney because the bladder is flappy, pelvic mass is pushing or making the anatomy and making the anatomy unfavorable to do the punctures. And in case of radiation cystitis, possibility of bleeding, a lot of course if you cannot do perfect punctures. And then in case of vesicocolonic or vaginal fistula, it's better to be precise, and you are going to put a catheter and the image guided. The absolute contraindications, bladder tumors, and there is another absolute contraindication. Whenever you are in case of traumatized patients, and when they are calling you, the general surgeon say that there is no any, for example, surgical problem, and the patient has got pelvic fractures and we have got hematoma surrounding the bladder. It's better in this situation not to do punctures because you may end with bleeding. So it's better to do a formal suprapubic cystostomy in such cases. This is my personal idea, and it's very difficult in some situations to inside the bladder. So it's better to leave them under spinal or general anesthesia by formal suprapubic cystostomy in case of severe traumatized patients. Relative is new bladder, those patients who have got their bladder, who have got bladder tumors. Radical cystectomy has been done for them, and new bladders new bladder has been made from the bowel, and it's called urinary diversions, whether it's from a small bowel or from the colon. It's called a new bladder. It's sometimes also difficult because there is a lot of loop of bowels and disturbed anatomy, that there's possibility to puncture or to make injury to the surrounding bowels. Abdominal wall cystitis, because it may induce infection inside the bladder. And this is the ultrasound guide cystostomy, in the A. The ultrasound, and there is this area, the suprapubic. The patient has been well prepared and draped well, and after cleaning all these areas by aseptic technique, the urologist or radiologist is going to start to puncture the bladder. And then you are going to push your needle inside. The B, it's ultrasound picture showing the needle inside the bladder, and the urine is dark in color, sorry, and surrounding structures are gray in color. Sorry. Complication, hematuria, skin infection, bowel perforation, and long-term complication is UTI and stone formations. And embolizations indicated in cases when there is bleeding. In case of, for example, PCNL, in case of sometimes you have got a big tumor, you are going to decrease the vascularity in order to make your procedure simpler. You are going to embolize the renal artery. And then in case of big angiomyolipoma, a bleeding angiomyolipoma, in case of end-stage renal diseases, where surgery is contraindicated. Alternative to nephrectomy in unfit patients. And this once you do embolization, the patient will start to have auto-nephrectomy. It means decrease the size and, sorry, and it will shrink. Renal artery aneurysm or arteriovenous malformations. In cases of, as I mentioned, in case of bleeding after PCNL, or in case of pseudoaneurysm after PCNL. No surgical contraindications. We have got the relative uncontrolled ureteric sepsis and untreated coagulopathy. We all know that this procedure is done when you are going to under. It's done usually under image guided, usually fluoroscope. Should be there. You are puncturing the femoral artery. There is special guide wire, and after you follow this guide wire, you put your cannula, special type of catheter, and then you visualize the aorta and the kidney and the renal artery, and you are going to go to the targeted vessels, and then you embolize. Complication, degradation of the embolic agent. Complication related to angiographic technique, for example, renal artery wall dissections, intimal injuries and dissection, groin hematoma at the site of your puncture, post-embolization syndrome, and rarely renal failure, and you have infections, sometimes followed by infections, or your procedure has not been successful, called incomplete embolization. This is how we are getting the catheter is at the renal artery and sending the stent is there. You are visualizing the renal artery, visualizing the offending vessels of pseudoaneurysm, and then you are going to push these coils or coil emboli to obstruct these feeding vessel of pseudoaneurysm. This is another picture showing the procedure. Varicocele embolization is a new. You all know what's the varicoceles and the type of operations and the indications of varicocele, which is dilated tortuous, elongated papilliform plexus, venous plexus, and we are not going back to details of what's the varicocele, but one of the route or type of treatment is to do embolizations, and usually done by interventional radiologist. And the indications, these are the indications of varicocelectomy, just to review. The contraindication of this procedure is relatively primary infertility, aberrant gonadal vasculatures, and untreated coagulation. Certain type of primary infertility, certain type of primary infertility. We are not going to embolize, not all types. Complications, recurrence, as in other type, in other ways of treatment. For example, surgery, you have got chance of 20% of recurrence, but the best way to treat the varicocele is under magnification or microscopical surgery, which is the rate of complication is only about 6%. Other type of complication is migration of embolic material, testicular thrombophlebitis, and complication relating to the vascular access, bleeding, hematoma. These are shown picture of embolizations. In case of transplantation, you just take a biopsy or like a native kidney, an obstructed ureter, or a stone in the ureter, strictures, or collection of fluid or lymph surrounding the kidney. This is a transplant kidney in the right iliac fossa. Percutaneous nephrostomy following by stent. The stent is there. Nephrostomy tube, this renal artery dilatation in case of transplant kidney. And thank you very much.